think we're going to get started. Look, I need a step stool. Still a few more people coming in. Come on in. So we first wanted to welcome everyone and thank you all so much for joining. This is so fantastic to see all of you here in person. Many people I know, some I don't. Really just so amazing to all be here together. For those of you who remember, we've done this. We did this many years in a row for a long time. The pandemic got in our way. We did it virtual for a few years in a row, but it's really great to be back in the room with everyone together again. I'll introduce myself for those of you I don't know. I'm Sarah Goldberg. I'm a medical oncologist specializing in lung cancer. And I'm one of the co-directors of the Center for Thoracic Cancers. I treat patients here in New Haven as well as in North Haven. And again, it's so great to see you all and welcome you. I'll let my co-moderator here introduce himself, and then I'll make a couple more remarks.
Thank you. Sarah Goldberg and I went to middle school and high school together on Long Island 30 years ago. So
that's your introduction.
Pretty close. Justin Blasberg, I'm from thoracic surgery. I spend most of my time in New Haven and in North Haven, Greenwich, and Waterbury. And so thank you guys for coming. We have a packed agenda tonight, so we'll try and stay on time. But I guess, do you want to start with?
Yes, let me make a couple of remarks. So I just wanted to say a few introductory comments about lung cancer and about why we're all here. Justin will then tell you about what we're going to be talking about today, and then we'll get into it. So first, before I forget, I wanted to thank a few people. So first, I wanted to thank all of you for coming. This wouldn't be possible without all of you here and being interested and wanting to learn more. We are recording this, so thank you also to the people in the future who will be listening to this. There's no virtual audience right now, but we are recording it and we'll distribute it later. I also wanted to thank Renee Gaudet, who's in the back, helped to organize everything, made these beautiful agendas, got the word out. Amazing, amazing work. So thank you so much, Renee. And then to all of our speakers and panelists. So we got very excited putting this together for all of you, and we invited so many people, and everyone said yes for the most part. And so we have more than 20 faculty members and staff and research colleagues. I mean, so many people. You will know some of them, and some of them may be more behind the scenes, and you'll get to know them. But more than 20 people are here to teach you all about lung cancer and to educate you today. So why are we here? Well, lung cancer is a really common cancer. It's actually the second most common cancer in the US and worldwide. Breast cancer in women and prostate cancer in men is more common, but lung cancer is a big problem. And so we know that anyone with lungs can get lung cancer. There are risk factors, which we could talk about later, but we know anyone can get it regardless of risk factors. It can happen, and it can happen at any age. Most people are older, but there's plenty of young people as well. And so this is a disease that impacts so many people who get lung cancer, family members, friends. And so that's why we're all here to learn more about it and also to inspire hope. There's so much progress that has happened in the last 10, 20 years, even in the last year in lung cancer, in terms of how we're diagnosing it, how we're treating it. And we really wanted to make sure you all knew that you were hopeful for where we are now and where we're going in the future. And you kind of knew what the status of today is and where we're going for tomorrow. So it's really absolutely incredible what's happened in the development of drugs and all different ways we're treating lung cancer. Multiple new drugs have been developed in the last even just couple of years, and it's really a different world we're in today. So we know because of all of that progress, the number of people with lung cancer is going down, and also how long people are living is going up. People are doing better overall. It's for a few reasons. Screening, right? We're going to talk about screening today, diagnosing lung cancer early, and then also our great treatment. So there's a lot to be hopeful about and to be excited about. And again, really excited to have you all here. And thank you again. Turn it over to Justin to tell you about the plan for this evening.
We'll start with Doctors Woodard and Glendening, talking about recent progress in diagnosing, treating, and curing lung cancer. We'll have a panel discussion led by Dr. Herbst and company to sort of do a deeper dive into that topic. We'll talk about supporting patients and family through their cancer journey, led by Dr. Chiang, and also a moderated session to follow. We'll talk about the impact of lung cancer screening with Dr. Tanoue from pulmonary, and we'll have a session after that as well, and then do a deeper dive into some of the research that we're doing here. So I think we will start with Drs. Woodard and Glendening first talk. Welcome.
Hi, good evening, everyone. Thanks for coming. This is, of course, a 10-minute talk on a topic which we have conferences that span several days and multiple rooms on. So we'll try to cover a lot of content kind of at a higher level. But thanks for your interest. There has been a lot of progress made even in the way that we diagnose lung cancer. Lung cancer screening is now finding cancers at an earlier stage. There's going to be a whole talk devoted to this topic, so I won't dwell on it. But we're diagnosing lung cancer in a stage where it's very easily treated now for many patients. We also have improved methods for biopsy and diagnosis. This can often be done, without even putting local on you. You can be gently sedated and have what's called an EBUS. And so that's what's shown here. But so patients are asleep, we put a bronchoscope, which is a long camera down your mouth. And then samples can be taken of your lymph nodes, and samples can be taken of lung masses that we're worried about within the same setting. This has expedited our ability to quickly make diagnoses and to get more information to properly stage patients. And I would say it's a preferred option for us as providers, but also something that I think really takes the patient's experience into account. So there's been a lot of progress made in this space. When we think about our general treatment options for lung cancer, we can divide these into two broad categories. We have our local therapies. This would be something like surgery or radiation, or sometimes ablation is used. But these are things that really treat only the area that you're delivering the treatment to. So for surgery, it's whatever is taken out. For radiation, it's wherever they target their beams. And those really go to a more focused area when a disease is contained. Then we have systemic therapy, and I will let my colleagues talk more about this, but this generally falls into three buckets. Cytotoxic chemotherapy, which is when you think of chemo, that's the old school, oh, you might lose your hair, but it targets dividing cells. Then we have much newer therapies that have really come out in just the last 10 years or so, some of which were delivered for the first time by my colleague, Dr. Glettinger. But things like immunotherapy, which uses the body's own immune system to attack different tumors, and then targeted therapies, which go after specific mutations in tumors. These other therapies can be well tolerated, and they're not as toxic in certain ways that we think of chemotherapy as very hard for patients to handle. These can be much better tolerated. Dr. Glettinger?
So it's great to see all of you again this year. Many of us have known each other for several years, some now 10 years after initial diagnosis and treatment for metastatic lung cancer, which really speaks to the progress that has been made over the last couple of decades in lung cancer. Gavitt really talked about the different types of therapies. I just want to talk about a little history, I guess. I started here at Yale about 20 years ago, and I feel fortunate to have been able to treat patients with lung cancer and to do associated research. When I was initially doing training in oncology, I don't think many of us were really interested in lung cancer. We didn't have many good therapies. Questions we were asking were, is one chemotherapy better than no chemotherapy? Is two chemotherapies better than one chemotherapy? And I bet Roy Herbst, who's our chairman and chief, would tell you that, it wasn't the most exciting field at the time. But since then, things have changed dramatically. And I think many of our young, our fellows are very interested, not only because Roy is our chair, but because there's so much going on in lung cancer. And I would say over the last two or three decades, there have been two major breakthroughs in lung cancer, and other cancer types have followed these breakthroughs. The first one was in early 2000, where a mutation was identified in a gene called EGFR among a small group of patients who were enrolled on a big trial evaluating a targeted drug that targeted EGFR, epidermal growth factor receptor signaling. This is a growth pathway. It's important for normal cells as well as for cancer cells. And in this trial, there was maybe 10% of patients who responded, and this ultimately led researchers around the country, including Tom Lynch, who used to be here, to sequence to read the EGFR gene, and indeed a mutation was found. And this really heralded a new era of cancer care for our patients. We could now personalize cancer therapeutics. And remember, Roy, back in ASCO in 2000, between 2000 and maybe 2010, it was always how do we best personalize our medicine? And so many additional targeted therapies have been developed. And in lung cancer, other subgroups have been identified. Maybe 20% of lung cancers, we find one dominant problem in a gene that's mutated that allows us to give an oral targeted therapy that is quite effective. Some of these are ALK. Some of you, I can see one person, ALK, ROS1, BRAF, MET, HER2, and there are more. But again, it's only 20% of patients. And many of these patients are non-smokers, and people think lung cancer is a disease of smokers. That is definitely not the case. And as we go on, as we have more screening, as smoking, less smoking, we're going to see much more prevalence of non-smoking lung cancer. So the second major breakthrough happened, I'd say, 2009, 2010, and that was with immunotherapy, where we saw responses in patients with lung cancer to immunotherapy. And immunotherapy wasn't new. And we had been trying immunotherapy for decades. I don't know, Roy, were you involved with any vaccine trials back in the day? And we learned that immunotherapy does not work for lung cancer. It's not an immunogenic cancer, and all of our trials failed. But 2009, 2010, there was a phase 1 trial of a novel immunotherapy called an immune checkpoint inhibitor, more specifically a PD-1 axis inhibitor. And we saw responses in patients who had lung cancer. And if you think back to that time where we evaluate these new trials, these new drugs, we use phase 1 trials where there's a lot of different pharmacokinetic studies and other things. And the patients who go on to these studies, they tend to have poor prognosis, maybe three to 6 months. They've already seen all the standard therapies, and they're willing to go on to phase 1 trial and deal with the toxicities. And before this particular trial, I had run some other phase 1 trials, and I always felt very uncomfortable because these were very toxic. And I knew my patients had a short time to live, and I didn't really want to give them a drug that was going to worsen their quality of life. And the first thing I recall from this trial of PD-1 axis inhibitors was that patients tolerated it very well. In fact, most patients had little or even no side effects. So I felt much better about putting patients on this trial. And then we started seeing responses. And this is the potential of immunotherapy. Patients who responded could be quite durable, much more durable than chemotherapy and even targeted therapies. And from that first trial back in 2009-10, where we had these patients who had very poor prognosis, patients got 2 years of therapy. I'm still following patients from that trial who haven't had any therapy for 10 years, and living a good life. So clearly, immunotherapy has changed the way we do things, not only for lung cancer, but for all cancers. So since then, so that was in the metastatic setting where we used these immunotherapies, and the first drug was approved for lung cancer, the first PD-1 axis inhibitor in 2015. And from 2015 to now, what we've basically done is we've developed new PD-1 axis inhibitors, one type of immunotherapy, and we brought it in earlier, to early stage lung cancer, stage 2, stage 3, where the goal of therapy is cure, and these therapies increase the chance of cure. But we've hit a wall, outside of these PD-1 axis inhibitors, we really haven't found another immunotherapy that's going to help patients who don't respond to these drugs. So let's see. So at Yale, the way that we're going to move the field forward is by running clinical trials of novel immunotherapies and doing what we call translational research. So we take discoveries from the laboratory, we develop drugs, we bring them to the patients. And then we take discoveries from the patients, observations from the patients, we bring them back to the laboratory. We build upon them, and then we bring them back to the patients. And so this is one thing that we all do here at Yale, and certainly I've been doing it. And the way I've done it with Katie Politi here is we devised a protocol many years ago, which allows us to look at tumor tissue from patients, try to understand things. And we have several hundred patients who have graciously enrolled to this protocol. It doesn't really require much from patients other than allows us to do some additional studies from their tumor tissue. And so one one effort right now, which we're very excited about, is looking at our patients who get immunotherapy who have durable responses. These are patients who are beyond 5 years with metastatic lung cancer who are still doing well without evidence of cancer. And we want to know, why? Why are these patients having this great outcome and others don't? So we've collected 60 of these patients, and we're right now looking at different clinical characteristics, pathologic characteristics, and we're going back to their pathology specimens. We're looking at the DNA, the blueprints, we're looking at proteins, and we're going to try to figure this out. And thanks to you, many of you here who are involved in this protocol, we are going to find the answers, and we're going to be able to provide therapies to patients who currently are not responding to immunotherapy. So I thank you for all that, and I will move it on to you, Gavitt.
We have a panel now, so.
No, I think we have, she's going to finish her talk.
Okay.
See what the slides are.
I get other stuff.
I can quickly go through this, but your treatments for lung cancer are primarily determined by how extensive your tumor is, and we use stage as a guideline for this. Stage 1 lung cancers in general are smaller tumors, smaller than 3 centimeters, that have not spread to any lymph nodes. Stage 2 tends to be smaller tumors that maybe have spread to a close lymph node within the lung, but are still fairly confined. Stage 3, we start to think about these as spreading to other areas, particularly the mediastinum. And stage 4 is when you have more distant sites of disease. In general, we like to use local therapies for earlier stage tumors. And when we think that there is concern for cells that might have spread to other parts of your body, we like to pair these with systemic therapy. And when we have disease that's traveled to distant places, we no longer see the benefit in local therapy as much, so then we focus primarily on systemic therapy. In terms of, as a surgeon, I'll talk to you very quickly about surgery. I would say that the progress that has been made recently tends to be in the surgical field and more minimally invasive approaches. We do most of our operations here at Yale robotically. If you need a bigger incision, it's just because we're trying to do what's safest and best for you at that point in time. This is an example of what some robotic incisions look like, but you can see that the recovery from this is a little bit easier than a big incision. Most patients leave the hospital in a few days, and we're very focused on patient outcomes and patients having a quick recovery and return to baseline. In treating lung cancer and curing lung cancer, as was discussed previously, research in this space is exploding, and we've seen huge improvements in survival, particularly among patients who have a response to either targeted therapy or immunotherapy, and they can have some very long-term responses to treatment. I'm going to leave up this agenda, and we'll go to our panel next.
Okay, so now it's time for you to ask some questions. So Gavitt will join the panel, and we have Scott, and we're going to ask Mike Grant to come on up, Sanja Dacic, and Henry Park. So I'm Roy Herbst, and thank you, Scott, for all. Scott's actually my hero. When I've been at Yale now for about 14 years, and I was at MD Anderson, the biggest cancer center in the country, and actually I learned about immunotherapy from Scott, because Yale is really one of the 1 or 2 places in the country or the world where immunotherapy was first developed. And the fact that there are people living for 14 years or 13 years is amazing. But the problem is it's not everyone, so we have to keep working and finding new drugs. But we have a great panel. We have Scott, who you already met. We have Dr. Sanja Dacic. She's our vice chair of pathology. It's all about the tissue. We have to understand what about the tissue and how are we going to best target the cancer. She's very esteemed. She's one of the leaders in the world in pathology of lung cancer, so we're very happy to have her here. Then there's Michael Grant, right? Mike was one of our fellows, so he trained here at Yale, and he practices actually out in Waterbury. Who here is from Waterbury? So you don't have to come all the way in. You can go to Waterbury. And this guy, he's one of our top fellows. He's out there. He's just amazing. He's only been in practice a couple of years, and you don't only do lung cancer. You do a little something else once in a while too, but really focused on lung cancer. Then Henry Park. Henry's our radiation guy, and this is multimodality. We have to really bring together all the different groups, and Henry is a Yale product, and he's just one of the top leaders in radiation oncology. And then you met Gavitt, who we were able to bring over, 4 or 5 years ago now from San Francisco. It's much nicer in New Haven, right? So we have an amazing panel. And what we do is every Monday across the hall there, we meet and we have a tumor board and we discuss, what can we do best? Everyone needs the best personalized therapy. So let's see, if there are any questions, I'll take those first. If not, I'll ask some questions. But does anyone have any questions? If not, I'll start with Mike. Tell us a little bit about how you function. You're out in Waterbury, you see a patient. How do you interact with all the pathology, the specialists, the tumor board, when you see a patient and decide how to treat them?
Yeah, so I am up in Waterbury. I also see patients a half day a week in Torrington, Connecticut. And, we've built a nice thoracic oncology program with surgeons, radiation oncologists. We've done a lot of reaching out to the community sites, pathology and radiology. And so it's important, that we bring the standard of care that we have here in New Haven up to the sites in Connecticut. And I take a lot of pride in that. And that's something that we've, I think, tried to do over the 2 years that I've been up in Waterbury. But it's really important to keep interfacing with New Haven in terms of the most up-to-date research and techniques in pathology and in radiology. We also have the opportunity to present patients at tumor boards in New Haven, and we have clinical trials up in Waterbury as well. So I think it's been a really, amazing experience to be able to take part in integrating New Haven into the areas in North Connecticut.
That's great. We have 15 sites now. We even have a site in Rhode Island, Westerly, Rhode Island. It's nice if you like boating, you can, take the boat right up there. But it's amazing. You get the same care, the same protocols, because we have specialists in all places. Now, Sanja, so the reason why we've made so much progress in lung cancer is we've defined it. So we don't just treat everyone the same like we did when, I'm a little older than Scott. I'm the oldest one here. So, but Scott, we used to just treat everyone the same, but now we take the tissue and we analyze it. Some people have smoked, some haven't smoked. Some have been exposed to asbestos. Some have no exposure they know of. And maybe it's a family thing that we haven't figured out yet. But Sanja will take the tissue and analyze it in real rapid time, and her team. You want to say a few words about tissue profiling?
Sure. I'm a pathologist, so you're never going to meet me in person. I'm in behind the scene together with my group of pathologists. But you may see our signatures on the reports, and we are very happy to be part of the group. And one part, of course, is to make the first diagnosis to tell which tumor type you have, because it makes a difference how you're going to be treated. But the most exciting part is really looking into the genes and defining the genetic profile of your tumors, because this is really what's driving the entire oncology team, even like a surgery team now, research that we have here, and what we are trying to do, because there are lots of complaints, as you know. The reality is that not all of the lung cancer patients are able to get testing, and we are trying to improve that and make it actually available to everybody, but also to give the results fast. Because we know that we cannot wait for 3 or 4 weeks to get the results, because you must be very anxious. So I could imagine how anxious you could be waiting for the results to see how you're going to be treated. So we are really trying very hard with some new technologies that we have to bring this hopefully within 3 days after you see your oncologist. And there's also a very exciting area of computational science that can also give us a lot of information from tissue without actually running through big machines and lots of time, that actually we can give you results maybe in a couple of hours. So that's our goal. What's that going to happen? I'm not sure, hopefully in a year or two, but we are working really very hard to get there and to provide excellent care to you, which is already excellent anyway.
Amazing, because you can't make a mistake. It's got to be 100% precise, but quick. And we're always calling her. I see some of my patients. I actually see some family out there. And I call Sanja and I say, you got to get it like tomorrow. We all call you that way, but we can do that here. And it's a really personal approach. Now, Henry Park. So Henry's a radiation oncologist, and radiation's a very important modality we use in localized therapy. We have some of the most recent technologies here at Yale, and I think we just broke ground on our protein facility. Do you want to say a few words about that?
Sure. So, we offer the same service also throughout our care centers as well. We don't quite have 15 centers here. We have about 6 or 7, but all throughout the state as well. And we're actually upgrading our machines really at all the places right now to make sure that we're we're able to offer the same kind of technology to everybody. So I think really IMRT, or intensity modulated radiation therapy, is one of the biggest advances that we've had in the last 10 or 15 years to really customize the shape of the radiation dose to not just be a square or a circle, but to really be to really be almost any shape we want. So it really helps to shape the high dose, and you get some low dose scatter as well. And what proton therapy is going to do is hopefully get even less of that low dose scatter also. So we can treat to even higher doses where we need to, and then also spare the normal organs around the area that we're targeting to really spare you from side effects as much as we can. So we've made a lot of advances in this area as well, and we have a new machine here as well that uses a PET scan signal as well to be able to drive where the radiation goes. So it's kind of like a self-driving car. So not everyone's eligible for that, but there are some patients, especially those with stage 4 disease and just only some small spots that light up on the PET scan, that we're able to actually track using the PET signal itself from the tumor and drive the radiation. So I think we're always moving forward in terms of how to use radiation in combination with surgery and with systemic therapies as well, and we're here for you.
Thanks, Henry. Start thinking about your questions because I'm going to open up again. But Gavitt, so Gavitt's amazing, triple threat, because she's not only an amazing surgeon, and but she works in the lab. I see her in the lab on Tuesdays and a couple of other days, and she teaches. Probably have a lot of other responsibilities too. How do you do it all, and what drives you? What's motivated you to to do all this?
I think this is probably true for all of us up here, but we really love what we do. It's interesting, it's rewarding, it's, great. It gives you tons of energy to come out of a clinic where you've seen a bunch of patients who are grateful for the care. Lung cancer care has gotten very complicated, but that also keeps it very interesting. And it's a pleasure to work as a team with our colleagues. We now have clinics where we can provide multidisciplinary care for patients. So I have clinic with Anne, I have clinic with Rick, I have clinic with Roy sometimes. And so it's nice to have that overlap, and we can see patients in the same setting. You get 2 different specialties seeing you without you having to go to different clinic visits or different appointments or locations. And so I think that really drives better care and more patient-centered care. And we all like each other and get along. So it's fun to work as a team. And my favorite part of the whole week is always tumor board, because I like seeing my colleagues. I like talking about lung cancer and thinking about the different and clever ways that we can, create personalized treatment for all of you guys in the audience.
Excellent. And we take some questions now. Anyone have a question? Oh, excellent. Maybe Jen Pope, can you bring the microphone out to him, please? Jennifer, she runs our clinical trials unit. Really important, because clinical trials, the immunotherapy, the patients that are 10, 14 years out, those were clinical trials. So that's how you get the most advanced therapy, the clinical trials. So yes, please. Good.
Working now. We have so many wonderful people here solving our problems. I'm wondering about how much sharing of knowledge you do with other cancer centers like Sloan Kettering or Mass General. Is there a flow of ideas and results, tests, sharing of knowledge with other cancer centers that may be going in somewhat different directions than Yale?
That's a great question. Scott, do you want to take that one?
So we work a lot with other cancer centers, the ones that you mentioned, and others further west. We do clinical trials together, and we have many different research efforts. So you can imagine the more patients that you have, the more statistical power you have to answer certain questions. So Katie Politi, who's a scientist here at Yale, who works with EGFR as well as many other things, she can talk to all the different collaborations she has across the country. So we might have patient samples, and then we might take, for example, samples, and we'll bring them to Katie's lab, and she might grow it in a mouse, and then she'll do some studies on that, and then she'll send the mouse to another lab, and then she'll get something. So we work a lot with other cancer centers.
Yeah, let's give Katie the microphone. So it's 20 years since the EGFR mutations were discovered that allows us to use some of these targeted therapies. And Katie and I lead a big grant here called the SPORE. And we were holding the meeting here in New Haven, and Katie said to me, why don't we have the meeting here and we'll celebrate 20 years, we'll invite everyone. And I said, we can never do it. Well, we did. And do you want to say a few words about the meeting we had in June?
Yes, absolutely. Good evening, everybody. It's really a pleasure to be here and see all of you. So we had a meeting in June, and we had several hundred people attend this meeting, and it was really focused on celebrating and recognizing and talking about what has happened in the past 20 years since the discovery of EGF receptor mutations in lung cancer, because that really transformed the whole field. And these mutations were found, then drugs were found initially and then developed that, other drugs were also developed, better ones that could be used to actually treat these tumors that have EGF receptor mutations. But with that discovery, then people started working and looking for other alterations in tumors that also could be targeted and other drugs that could be used. And so we really all came together and talked about the history of that discovery. We talked about the present, so what that discovery meant and where we are now, and also about some of the challenges and things that we have to do in the future to really solve some of the big problems, like the problem of resistance. So these drugs work initially, but then they stop working and resistance comes up. So this was really, it was amazing to gather people from so many institutions, and we collaborate with many of them. So there's constant exchange of information.
Right. We had people from all over the country, Mass General, Sloan Kettering, and MD Anderson, California. And actually, they're having a similar meeting now at the Royal Society in London in December. So Katie and I are actually presenting a paper there. So it's an international collaboration. And actually, we're one of the focal points because, Li Ping Chen, who's out at the West Campus where we had, the old Bayer facility, it used to be a movie theater 40 years ago when I was a student here. That's where we hold our meetings, and we have big space. It's just wonderful. Okay, more questions. I'm sure there are some more. Yes. Okay, good. There's one in the front, Jim, but why don't you? I'll tell you, we've done this for many years when I was always organizing it, and we never had this many people, but Justin and Sarah and Katie, our leaders, what a wonderful job. Okay, where's the question? Okay, yeah.
So, you see in the lay press about mRNA vaccinations for tumors.
Yeah.
And just wondering what the status of that is specifically with lung cancers at this point.
Okay, who wants that, gang? Either maybe Sanja or maybe Gavitt. Scott, you take it, Scott.
So, we've done vaccine trials in lung cancer for decades, and they never worked. And part of the problem may be that we didn't add something like an immune checkpoint inhibitor. And there's reason to think that that's important in conjunction with that. There are, I personally am not involved with any messenger RNA vaccines, but it's definitely an approach that is being looked at, and, to improve the vaccines upon the past. There are many other immunotherapies too that we can combine with vaccines. But I don't know, Roy, do you know of any other?
Yeah, well, vaccines will work because we want to get the immune system to go after the tumor. The problem is all the vaccine trials in the past were failed because of this immune checkpoint. We didn't give it with a Keytruda. We didn't give it with an Opdivo. You have to give those drugs together. So now what's happening is, these mRNA vaccines, helped us get through COVID. Moderna and Pfizer, the stocks all went up. But now, no one's getting the vaccines anymore. So they're focusing. But you should, by the way, because it's back. But what they're doing is they're focusing now on cancer, and it's a little bit challenging because you have to identify what is it about the cancer that you put into the vaccine. So oftentimes you have to make a personalized vaccine, and that can take 4 to 6 weeks. But these companies are now doing these trials. We're combining them with the checkpoint inhibitors. And one point I want to make, and maybe we'll take the question in the back and then say a few words about early disease. We're taking all these new therapies in the advanced setting, and you'll hear about that in the next panels. We're moving it earlier, after surgery, in the adjuvant setting, even before surgery. But before I go on, I think there's someone waiting in the back with a question.
So it's more of a statement than a question. I'm 5 weeks post-op after Dr. Blasberg did an amazing job on me, and I'm now seeing Dr. Goldberg for follow-up care and started the targeted therapy for the EGFR gene. I've never smoked, and I've gotten quite the education on lung cancer in the last couple months. Not one that I would have expected to have gotten. So I'm just so grateful and a lucky recipient of your research. I wonder though, do you use patient testimonies? Do you have the patients somehow collaborate with you all to talk about their experience? And if not, I would highly recommend it. Sharing my story, as I guess it's become, it has been really important for me in healing and in the psychological journey of dealing with this. So if you can collaborate with patients, I think that would be mutually beneficial.
Is Renee Godet still here? But yeah, we would love, first of all, I'm glad you're getting great care. And you realize that treatment that you're getting was based on a trial called ADURA, which was a trial that, a worldwide trial, 800 patients around the world, but it was led from here. So it's wonderful. That didn't exist 5 years ago. So that's wonderful. And by the way, we're doing that not just for the EGFR, but for ALK and ROS1 and all the different mutations. So that's Renee. She's very bashful, but she's in the back. But if you want to talk to Renee, she does a lot of our communications. And yes, we want people to be advocates to help people when they get this diagnosis. Who do you ask? Where do you get information? You go on the web. It's very hard to navigate. I know I do it for my own family for different things. So we're here to help. So thank you for your generosity. Yes, please. Another question.
It's on now.
In light of what we can expect from the next administration, what concerns do you have with the massive changes that are predicted to be in the healthcare organizations throughout this country and in the quality of healthcare that we can all expect?
Okay, that's a tough one. But I'll only ask for volunteers here. If not, I'll have to handle it as the moderator.
I can start. So, obviously we're not sure yet exactly what's going to happen with the healthcare system in the U.S., but we do know that funding, that has already been going down for the National Cancer Institute, the NIH as well. So I think the cooperative groups, the one thing I want to mention was clinical trials are often run from institutions like ours and collaborations that we have with specific places, but also there's cooperative groups as well that are run from the National Cancer Institute as well, where we actually have a lot of leadership in a lot of those organizations as well, and really partake in that. And even already we've been seeing some loss of funding from there. So I think what's really going to take it's a lot of advocacy from you all, as well as from us to really push for more funding that we can get from the government to do the research we want to do and to run these kind of clinical trials, because they are expensive and it's and labor intensive, and it really isn't easy to be able to fund all these things. So I think it's very important that we continue to make this a priority in the government and to advocate as much as we can.
Absolutely. I chair a committee for the American Association of Cancer Research. Cancer is not a political thing. Every Republican, Democrat, Independent, everyone has to face cancer, unfortunately, themselves or in their families. So there's always going to be support. It just is a problem that it's a zero-sum game sometimes, and the money has to be apportioned in different ways. Even if funding were to go down a bit, we'll have to leverage that here at Yale. So we have a strong program, a strong institution. The institution uses its endowment to help us a bit. We have a strong clinical program. And then we need what we call public-private partnerships. We'll have to work together with philanthropy. We'll have to work together with academia. We do alliances with industry. Some industry representatives are here. We'll all have to work together, but we'll continue to make progress and we'll do what we can. But it's always a challenge. I run a big group here, and we're trying our young people. The thing that worries me most is young people going into science, because it's education, mentorship, training, something we really do here. So we have to make sure that we fund the early grants, the training awards, so that more people, like we have on the panel here, will be here in the future. One or two more questions, and I have to turn it over. Any final questions from the group? Comments? Yes, please, on the right. We have time for two more.
What role do you think AI will have in the development of future therapies? And do you think AI will have a role in clinical trials?
That's a good question, because I bet Elon Musk will really push the AI. So what do you guys think about AI? Who wants to talk about that? Sanja actually works in AI.
There's a lot of excitement in the AI area, and mining of big data. That's one part. Looking into tumor characteristics, combining together with imaging studies. Lots of information can come out of it from imaging studies. So from the diagnosis to defining actually mutational or genetic profile of a tumor, leading to the development of drugs is very much here. And actually we see in the clinical trials also shift there. Basically, In the past, we had, certain assay developed for detection of the certain genes. Now we see AI actually doing it. And it's pretty good. It's really pretty good, and it goes fast. It really goes fast. And we see AI at all levels in a patient care, clinical care, medical care, everywhere, from pathology, from writing the reports, from everything, absolutely everything, diagnosis, prognosis. So the regulatory part is a big piece because technology is moving much faster than the regulatory piece, and this is why we have to be careful. And but I'm very optimistic, and I see we are going to see this more significantly in a clinical practice, and hopefully in a much shorter time than what happened, for example, with the development and implementation of EGFR testing. So
Right.
it's definitely coming.
Yeah, we can use it for drug discovery. We just have to be careful about HIPAA, about privacy. Yale's invested in its own platforms because we can't write a note using the outside platforms because the information here is confidential. But you can get a whole note now, and you can. Sanja can only scan so many slides in an evening, but the machine can do more. We're just about out of time. Scott, clinical trials are the future. You mentioned all the patients that you treated with immunotherapy, chemotherapy. How do people find out about clinical trials here at Yale? We're looking for trials to target the resistance mechanisms. You can just say a few words about that before we end, please.
Well, we need to do better in terms of publicizing our clinical trials, but when patients come to see us, we introduce them to the idea of clinical trials and we discuss with them different trials. We do different types of trials. One type of trials with pharma, and that's a very common type of trial. We also do trials with big cooperative groups where people from academia can ask questions that pharma doesn't really want to answer. And then we also do homegrown trials, investigator-initiated trials, where we develop a drug and we try to understand why some patients respond and some patients don't respond. So we take a lot of tumor specimens as well as blood, and we send it to different labs at Yale, and we try to understand things like that. There is the National Cancer Institute clinicaltrials.gov site where you can go, it's a search engine, and you can find any trial that's ongoing in the United States. Sarah, I don't know if you have anything else to add to that. Sarah runs our clinical trials program here.
Okay, Sarah, the last word, then Anne, why don't you come up and get ready for the next panel?
We actually have a whole panel at the end on research, so maybe we'll talk about it more then. But there's websites, clinicaltrials.gov. There's places you can look. It's complicated. It's like they try to put so much on there that sometimes it's hard to actually find what makes sense. So just ask. I think the best way to figure out what trials are available and what makes sense for you is to talk to your team. So I think we all know what's around and what's available. And then it was a great question that was asked about collaborating with other institutions. We do that all the time for research, but we also do it to help patients and to find clinical trials for them. So if we don't have a trial here, we often know where one is around that might be a good fit.
Okay, I want to thank the panel, and we'll move on to the next session.
Okay, let's have our second panel come up, everybody. And I'll say as they're coming, the name of this panel is Supporting Patients and Families Through Their Cancer Journey. And I think that just like Gavitt said, the reason why we're here really is because of you. That's one of the major reasons I think I myself and many of the folks here on the panel have chosen this career, is to be able to help you. And we're so grateful that you came out tonight, you and your families. And it's not easy to do an evening meeting, so we really appreciate it. So I'm going to have our panel introduce themselves. We'll just start with Dr. Possick. Jen, if you can introduce yourself and just talk very briefly about your role.
Hi, so I'm Jennifer Possick. I'm one of the pulmonologists who's part of the program. There are many different facets of what a pulmonologist does as part of this program. My particular focus is, oh no, well, the mic gets go next. So I'm there kind of to be with you during the entirety of your lung cancer journey. So I might be involved with you at the beginning when you're undergoing diagnosis. I'm also there to help manage your other pulmonary conditions that you have predating when you when you were found to have lung cancer, or other things that come up in the context of undergoing treatment. So either symptoms that you start to experience or problems that arise during your treatment. And we're really there to follow along with the entire team, to collaborate with the whole team at all different steps, and to help you to feel better along the way.
Sorry about the late appearance there. Mike Cohenuram, much like Mike Grant, I'm at one of the satellite offices. I see patients in Trumbull, Fairfield, and now Derby 1 day a week. So I'm definitely putting a lot more miles on my car. And much like Mike, with the same intent, we're really looking to bring the level of Yale care out to the community so that patients don't have to travel. And I would say, much like Dr. Possick, we're with you for the whole journey, from the time of diagnosis to what comes of it, from hopefully, a phenomenal success story. And unfortunately, sometimes the unfortunate things happen too, but we are always there supporting patients in every way that we can.
Hello, everyone. My name is Madelyn Kaehler, and I'm the manager of our supportive care program here at Smilo. We heard a lot of patient feedback pointing to the lack of education or awareness that we were doing with patients at Smilo, citing that they didn't know of the supportive care programs that they had available to them at Smilo. A lot of them are free and complimentary and really are to help patients cope with some of the side effects, the psychosocial side effects that you may be experiencing during a diagnosis. And so my team is a team of lay navigators that really help educate patients and families of the resources that you have available here. And part of our job is, of course, educating our providers to make sure that they know how to refer and utilize our team. But part of our team too is really there to educate patients like all of you on how to access our team, where to call if you need help or additional resources. My team is that. So we sit out of the resource center here in Smilo and New Haven, but we help patients all across the state and Rhode Island as well at some of the satellite centers. So.
Hi, everyone. My name is Michael Glendening. I'm a physician assistant. Some people know me as John. I go by my middle name, but you'll see both names in there. I work with the medical oncology team, helping people through their process of systemic therapies during, after, before we begin. And I'm happy to be a part of the team and happy to help everybody through that process.
Hi, I'm Maria. I'm one of the nurses with the medical oncology team. I'm usually one of the voices you'll hear if you're calling in with any questions about concerns to side effects or any symptoms that you might be worried about. So I'm usually one of the nurses that you'll talk to. Here from beginning of your treatment all the way to the end and so on for, forward. Sorry, I get really nervous public speaking. It's the first time I've done this. So I'm usually, from day one when you come in, you meet with the provider, we talk about your chemotherapy, we'll go over side effects, what to expect, when to call, and all those things. And so one of the voices you'll probably hear on the phone or you'll see me in person.
Hi, everyone. My name's Halley Robinson. I'm a clinical social worker here at Smilo. My job primarily is to provide emotional support to patients and families at all points across their journey with cancers. I work with patients and families both individually and in groups. I've run the lung cancer support group for the last 6.5 years here at Smilo, and I also recently started to facilitate the early onset cancer support group for patients diagnosed with cancer between the ages of 18 and 49.
Hi, my name is Kasey Hindinger. I'm a nurse practitioner in thoracic surgery. I work primarily in inpatient before surgery, during surgery, after, not in the operating room. And I'll see a lot of patients outpatient in clinic, helping them with their, recovery and so on and so forth. So we work really closely with the surgeons and sort of are the middlemen in between and can advocate and know the sort of the nitty gritty that can happen after surgery.
So you can see this is a sliver of our team who's here tonight. And these are all folks who are really you know, as they said, here from the beginning throughout your journey. And I think, again, what Gavitt said is true, is part of what makes this work easier and rewarding is also the team. I love this team. This is a terrific team that's around here, and they're all here for you as well. So, okay, so I have some specific questions that I'm going to ask about different parts of the journey, but I'm going to make sure and leave time for questions, or if you have a question, just raise your hand and we'll get you the microphone as well. So just to start off, so we talked a little bit about diagnosis and some of the resources, but I wonder if Dr. Mike and Halley, if you could talk a little bit about that really vulnerable time of diagnosis. What should folks keep in mind when they're diagnosed with cancer? What should they do or not do? And what specific resources would you want to make sure that they're available?
So I meet with many patients and families at their very first new patient appointment with the interdisciplinary team. I will tell you, those days are the scariest, most anxiety-provoking days. Oftentimes, it's me that pops my head in before you even had a chance to meet with your oncologist. You're full of questions. There's nothing more anxiety-provoking and scary than the unknown and not having any information. And so I think, regardless of what's discussed at those appointments, patients and their family members leave feeling so relieved after their conversation with the medical team, just having information and better understanding the next steps in their plan. I think those initial appointments can be very, very overwhelming in terms of the workup and tests, but each test that you're having better informs the next step. A piece of advice I would recommend is to stay off the internet during that time, because I think it's all of our natural inclination to try and fill in our gaps in understanding, when it's so important to remember all the intricacies of cancer care, lung cancer in particular, and the information that you're getting from your surgical or medical oncology team is specifically catered to you. So I just want you to keep that in mind.
I'm just going to add on real quickly that from a surgery standpoint, we also, for a resource, we have a lung cancer or lung resection book. So for surgery specifically, that we have for patients. So it sort of goes through, you know, what might happen, how long you might stay in the hospital, if you do end up getting treatment before, the test you might have. So it's a good resource, because it's not like Halley said, the worst thing you could do is Google anything. So it's important to, like, you have that book, but also you have your nurses, your team, your surgeons to answer your questions. So staying off the internet, but maybe might add too, like with the lung cancer support group, talking to other patients who maybe went through something similar. So talking to people is really the best thing, as opposed to, you know, looking up the stuff yourself.
Yeah, I restraining myself from saying amen when she said stay off the internet. I have never seen Google do anything but terrify people. I think later on, I would say most of us are more than happy to provide reliable internet sites, because we do want you to have the power of information. But there's fake news, there is a lot of fake information on the internet. I think the other thing that I would say not to do is, one, don't despair. This entire meeting so far has really outlined, there's been such unbelievable progress that it's not a question of what are we going to do now, but it's multiple lines of things that we're going to be able to do to help people. And I feel like there's a major step forward every year or two. So the longer somebody is dealing with disease, chances are there's going to be new option for them that didn't even exist at the time of diagnosis. I think what you should do, in addition to being hopeful and optimistic, is please write down all of your questions for your provider. This is what we are here for, is to educate you and to tell you what you want to know, and to tell us what's important to you. I think patients' priorities really dictate their care, and it's not what's important to us, it's really what's important to you and your family.
Fantastic. So let's move to, now you have a treatment plan, you're on a therapy, and you're worried about side effects, or maybe you're having some side effects. So maybe I could ask Michael and Maria to weigh in on your advice during this period.
Oh, side effects. So many side effects. And so much information that you get from us from the beginning of your visits with information about the therapies that you're going to be receiving, long lists of potential side effects, the irresistible urge to consult Dr. Google, and then worry about the things that could or may happen to you. I think because of time limitations, what I would say that is most important for people is to listen to your team and let us help answer your questions and reassure you. We have a very good sense of what all of the possible side effects are going to be for your individual therapies that can vary vastly, whether it's a combination of chemotherapy, immunotherapy, targeted therapy, or any of the individual therapies. We're here to help you understand those things. We're here to help address those issues. If they come up and when they come up, we're here to make this as smooth as possible for you. And I think our teams are very good at making sure that we can minimize the potential side effects and manage them so that you do well with your therapy and are able to get back out there and live your lives in ways that are satisfactory and satisfying for you.
And Maria, maybe you can also weigh in, since you get a lot of these calls and are on the other side of when do you call? Because that's a question, right, at home.
Yeah, we get that a lot. I tell patients, so after we have our treatment plan, we go over like the expected side effects. But I tell every patient kind of to, just take that with a grain of salt, because we don't know how things are going to affect everybody. I always tell them to stay off of Google as well. And I always tell them not to compare themselves to others. We know people who have friends that went through similar therapies and maybe it affected them one way or the other. So I tell them not to try to do that as much as they can. I know it's really hard. I tell every patient, you know how you feel before you start therapy, and you're the one that's more in tune with your body. So you'll know when there's something different that doesn't seem right. So despite all the side effects that we'll go over, if there's ever a question, I tell patients just call. If something does not seem normal or doesn't seem right for you, I always encourage them to call. I try to keep patients away from my chart with questions like that, because I think we like to answer these questions in real time, especially because we don't know how severe the symptom might be. So I always encourage patients, if there's anything that just does not seem right to you or that you're really worried about, or even a family member, I just encourage the phone call, and, we're happy to say, hey, this is actually normal, unfortunately, or, this is not normal. Let's, consider some more workup, or, where next steps.
Fantastic. And I always tell my patients, this is different from maybe your other doctors, your primary care, that you might sit on something for a while before you call. We want to hear about it. We'd rather take care of it until you don't have to worry about it than have it develop into something that needs addressing later on. So, we're here because of the lungs. And one of the questions that I get often is, what can I do for my lung function? How can I optimize my lung function? And I'm going to ask Dr. Possick, Jen, to weigh in on that. And Kasey, if you have any thoughts as well.
So I would actually even reframe it. And it's not even so much about what is your lung function. It's how do you feel? Like, what are your symptoms like, and what are you experiencing? And how can you go through all of this, kind of engaging in the activities you want to engage in, feeling the way you want to feel, and minimizing the things that come up along the way. And that's a way in which engaging with a team like ours, where a pulmonologist is part of it, though it doesn't feel like it at the time, is an opportunity, right? So it's an opportunity to learn more about your lung health in ways that are maybe totally unrelated to your cancer, and to help you feel as good as you can feel. So symptoms you're experiencing may have to do with your cancer. They may have to do with the treatments you're receiving. They may have to do with something completely unrelated. And kind of working with a physician in the lung clinic is an opportunity to tease that all apart and figure out, what can we do to make that better? Sometimes that's medication, sometimes that's strategies, and sometimes it's working on things like an exercise regimen. And so pulmonary rehab may be something that you hear about in the course of your treatment, right? And so pulmonary rehab is a structured exercise program specifically for people with lung problems. It shares a lot of similarities with regular physical therapy, but it has some particular differences in that it's really geared towards working with people who maybe have a lot of pulmonary symptoms or need very particular things out of their course of treatment. There's a program at Yale, but there are many programs all across the state. And they can be really, really helpful for people at all stages of their cancer treatment. But I wanted to make a call to, just though it's slightly unrelated, to say that much the way the Cancer Network is connected all across Connecticut, the pulmonary community is too. And so you may already have a relationship with a pulmonologist that you knew before this ever started. And more likely than not, we know those people and we have a relationship with those people. And we're here to work not only with you and not only with the rest of this team, but to work with the doctors who already know you well, right? And to collaborate. And so sometimes the care that we provide as pulmonologists as part of this team extends to working with the lung doctor who knows you beforehand as well. So.
And the only other thing that I would add besides like pulmonary rehab is, if from the surgery side, if you're preparing for surgery, patients ask what to do, and we're not going to turn you into like a marathon runner before surgery, but we do want you to, exercise. If you normally exercise 10 minutes a day, try to do that 5 days a week, and you slowly can increase it and try to increase your breathing capacity by, using this little special breathing tool called an incentive spirometer that, will give you in clinic if you're going to go to surgery, and you can see how you do before surgery, because after surgery, then you'll have an idea, okay, this is how I did before surgery. This is my goal. This is what I want to get to. And like that is going to help you ultimately recover, prevent pneumonia, and get you where you need to be. So just simple walking is good exercise. And another thing is if you smoke, just, if you can stop smoking, we have a really incredible smoking cessation program. So that is another way you can sort of optimize your lungs, at least prior to surgery.
Great. I have one more question for Madelyn, and then I'm going to open up. So think of your questions. Madelyn, you talked a little bit about the different patient or the navigation that you have for patient supportive care. And I guess I'd ask you just to weigh in on some strategies of wellness for our patients.
Yeah, so I'm the manager of the supportive care team, and what my team does is provide lay or non-clinical navigation to patients here at Smilo and the Smilo Clinical Network sites. So one of the teams that we support, of course, we send referrals to Halley and her team over in social work all the time. But in addition to that, we have an integrative medicine team here that really is a more complementary team that's focusing on your whole spiritual, mental, and physical wellness, and really reaffirms the importance of all of that while you're navigating a cancer diagnosis. So some of the resources that we have here are completely complementary to patients, and we have complementary massage, Reiki, meditation, online classes like yoga, Tai Chi, or chair-based exercise classes for patients. So for patients in far-reaching areas of Connecticut, Rhode Island, or sometimes even New York, they can log on to those classes and they don't actually have to drive anywhere at all. We also have a registered dietitian that focuses on holistic health approaches. Sometimes there are, there's a lot of that fake information patients sometimes find online, and a lot of that may be supplements or vitamins that actually may be contraindicate their chemotherapy regimens. So we have a registered dietitian on staff who really kind of helps debunk that with patients, and actually kind of can be able to piece out where things actually may be causing them more harm than good. So there's plenty of resources available for patients. We have a centralized phone numbers that patients are more than likely to call, or more than welcome to call us. One thing that we really try to do is engage with patients at the time of new diagnosis so they are aware that we are here and you can utilize us at any point throughout your cancer journey. 2 months in, 3 months in and beyond. I would encourage you all, if you are struggling with any psychosocial symptoms or anything at all, to just give our number a ring. We also handle any issues in terms of billing or financial struggles as you're navigating through your treatment. My team really helps navigate those conversations with patients and ultimately help patients kind of ease that burden. So there's plenty of resources here at Smilo. Sometimes we just, and I mean, this is my own feedback for our team up here. We sometimes get in our own way and don't get that information out to you all in the best way that we can. So that's something that we're actively working on.
Okay, any questions? I know this is an interactive crowd, so. One over there. If you wait you wait enough time, that people get over that initial fear. Thank you. Now they'll come fast and furious.
Is it on? It wasn't so much a question, but just to mention with the integrative medicine, your chaplain also. I've talked to one of the chaplains and have sort of an ongoing, every couple of months thing. And she's just absolutely superb. And it's not even for direct religious kinds of things. It's very non-denominational, but she's just an incredibly wonderful support, as was the massage.
Thank you for that comment. I think that it's really, it's not just, what care, what treatment are you getting? It's really the whole, I think cancer has changed in looking at the patient as the whole and trying to heal different parts, not just the cancer part, but the entire person and within the context of your family as well. And I think this team is really involved in that. Other questions?
Just a question about the support group. If you're not local, can you access that virtually or how's that possible?
Yeah, so at the start of COVID, formerly all of our support groups were held in person right here at Park Street. And with the start of COVID, we were able to very quickly switch our modality to be a remote model. So we continue to meet by Zoom. There's certainly pros and cons, but one thing I will say is it's really allowed the support group to be so accessible to patients no matter where they're living, no matter how they're feeling on that particular day. So we do operate by Zoom. If that's something you're interested in, I can give you my contact information and get you added to our list.
Okay.
I will say as a plug, the lung cancer support group is probably the most meaningful part of my work. And it has nothing to do with my relationship, but really just hearing from all the other support group members and seeing the ways in which they support one another. There are no words I can put to it in terms of how valuable it's become for our patients who have participated.
Wonderful. So I would like to get your.
All right, find me afterwards.
I will. Thank you so much.
Fantastic. And I think that's your community, which is also part of this community. So thank you for being part of that. Another question there in the middle? No? Okay, fantastic. Thank you so much. Thanks to the panel.
Okay, I think we'll get restarted so that we don't run too far over. It's really great to see you all here. You are our ambassadors, so hopefully you'll go talk to the world. And I see my patients there. Hi. I'm Lynn Tanoue, and I am the director of the Yale Lung Screening and Nodule Program. I'm a pulmonologist. I'm in the same section as Dr. Possick, who you just met. And I hope what you're getting a sense of tonight is that lung cancer care is very multidisciplinary and it takes a village to take care of you. So we're going to talk about the impact of lung cancer screening. And this is my first and last slide, I think. And so the people who are out there will get to see it too. And if you don't take away anything from the next few minutes, what I do want you to know is that the United States Preventive Services Task Force, which is the group that informs Medicare of what they should pay for, recommends annual screening for lung cancer with low-dose computed tomography, CT, in adults who are 50 to 80 years old and have a 20-pack year smoking history, who are currently smoking or have quit within the last 15 years. Time to screen is now. There are 14 million Americans who are eligible for lung cancer screening, and we have a long way to go to get those people screened. So I don't probably have to convince this audience that detecting cancer early saves lives. The purpose of any screening is to detect disease early before it hurts people. So every time you go see your doctor, you get your blood pressure checked, and a lot of you get glucose checked in the office. Those are screening interventions. If your blood pressure is controlled, you won't hopefully have a stroke or a heart attack. If your sugar is detected as being slightly high early, you can make a difference in terms of preventing the onset of diabetes. But you wouldn't know to do something about your early hypertension or your early diabetes if you weren't being screened. And those principles of screening really are embedded in cancer care. And all of us in this audience probably know about breast, colon, and prostate cancer screening, which has become part of everyday medical care. And screenings for those three cancers have made a huge difference in terms of improving quality of life and longevity in people with those cancers. And because of a lot of communication, public health efforts, information disseminated to the community, about 75% of people who are eligible for breast, colon, and prostate cancer screenings get screened. So let's talk about lung cancer. Lung cancer screening has been late to the table. It was first approved by Medicare in 2015. And as of today, about 140,000 Americans and 1.8 million people in the world each year will die from lung cancer. And those are numbers that we could decrease if we detected cancer earlier. And in contrast to breast, colon, and prostate cancer screening, right now, only about 5% of people who are eligible under those USPSTF eligibility criteria are actually getting screened. So I want you to go out and tell everybody you know who might meet that eligibility criteria. Just say, go talk to your doctor about lung cancer screening because maybe you qualify, because we have got to get that 5% closer to 100%. And so if we look back at what's happened in the US over the past 50 years, oops, you can see on the graph, on the chart here, I don't know if my mouse will show up. If you look at the top green column, that's breast cancer in women. And if you look at the column that is headed 1975 to 1977, so that's 50 years ago, the 5-year survival, meaning how many women, what percent of women are alive 5 years after their diagnosis if they were treated, was about 75%. Not bad. But the latest data are, this number has increased to 91%. So 9 out of 10 women who are diagnosed with breast cancer will live 5 years. And the majority of those women actually will keep living. We've turned breast cancer into hypertension. It's a chronic disease. People can live with that and live very well. And the boxes that are in green, which are those 3 other common solid tumors, have all had improvement in 5-year survival over this 50-year period. So has lung cancer, which is the box in red, but we've gone from 12 to 25%. And that increase to 25% really reflects all the advances that have been made in treatment, predominantly for advanced disease, the kind of disease that people fear because the chances that you can be cured or have a long life with quality are definitely diminished. So if the way that your cancer is found is because you have symptoms, it's more likely you will have advanced disease. And without screening, that's unfortunately how people get found. And so again, using breast cancer as the comparison, if you look at that pie chart on the left, at present, stage 1 and 2, which are early stage disease that are going to be identified by screening, are the blue and green parts of that pie chart. And you can see that the vast majority of women with breast cancer are diagnosed at early stage. And that is because the screening rate is so good, 75%. It's not 100%, and so some women are going to get found late. If it were 100%, the pie chart would be more blue and green. But diagnosing breast cancer early has really led to that amazing 5-year and very long-term survival for most women with breast cancer. So we've come a long way with breast cancer. If you look at the pie chart on the right, same color scheme, early stage lung cancer, stages 1 and 2 are in blue and green. You can see they're only about a quarter of that pie chart. So nearly, so 2/3 and nearly 3/4 of people with lung cancer actually are diagnosed late because they show up with symptoms. They're not detected early. And if we don't detect it early, our chance for cure, long-term survival with quality, go down. And so we need to change the color of that lung cancer pie chart to look more like breast cancer. And if we can accomplish that, we can hope to achieve the kind of long-term survival with quality that people with breast cancer, women with breast cancer, now enjoy. And so lung cancer screening will save lives. Right now, lung cancer screening is done with a chest CT scan. This is a pretty standard X-ray study. It takes about 5 minutes. You walk in, you don't have to take off any of your clothes. You lie down on a movable skinny table and you go through a donut. And you take one breath and you go whoop, through the scanner and then whoop, out, and you get up. You didn't take off any clothes. You don't have to put anything back on, and you leave. That's it. It's not an MRI. It's not closed. There are no needles. There's no nothing. Just lie down, take a breath, and then you're done. Painless, no anesthesia, doesn't require blood draw, one breath. So who in here has had a mammogram? That's no fun, right? But we go and we have the mammogram, even though it's uncomfortable because we want to be detected early in case we have breast cancer. Colonoscopy requires lots of anesthesia. And we do that too because we are concerned about the possibility of colon cancer. And, my care provider recommended that. And PSA is the blood draw, so you got to get stuck for that. So lung cancer screening actually is a lot simpler in the sense of pain, discomfort, time, on and on to us than all these other cancer screenings. And so I do want you to take away that it's actually pretty easy because there's a lot of misconception out there about how complicated it is. And before your first lung cancer screening CT scan, there's always the opportunity, and actually there's sort of a requirement to talk to one of us about lung cancer screening. It's an opportunity if people are smoking to talk to them about smoking cessation, to talk to them about the possible findings on the scan so nobody's caught by surprise, and to talk about the risk, your own individual risk of having lung cancer. So from an information standpoint, I think there's a lot packed into what is often a 10-minute discussion. Lung cancer screening is covered if you're eligible by those USPSTF criteria by Medicare, Medicaid, and private insurers. Connecticut was a state that accepted the expansion of the Affordable Care Act, and so even Medicaid in Connecticut covers lung cancer screening. And so if after tonight you want to know more about lung cancer screening, or you want to tell somebody that maybe they should look into lung cancer screening, and I hope you will, talk to your doctor, to your care provider. You can go to this now government-sponsored site, Should I Screen? If you put that in Google, patient, oriented site comes up that actually has one of the risk calculators that you can plug in your age and your gender and whether you went to college, and it actually will give you back a risk. You may not be able to make anything of that risk, and that's why you need to go back to your care provider and have a discussion, or you can call us or make an appointment to see us here at New Haven Hospital in the screening program. Part of the panel that's going to come up here are my ACE screening team. We're standing in the back, and so you'll be able to meet them tonight. And this is what that risk calculator looks like. You basically plug in the numbers. It's like a little Excel file. And at the bottom, it spits out a number of risk for you. Again, that's the part where you're going to get there and say, well, what does that mean? And that's why you need to call us. And so back to that original slide for those of you who are snacking out there, which I'm glad that you were doing that. Talk to your clinicians about lung cancer screening. Even if you don't meet these eligibility criteria, it's worth a discussion if you're concerned about yourself or about somebody you love. And that's it. Thank you so much.
All right, we're going to move into our panel discussion. We have Dr. Tanoue as part of that panel, and Polly, Sather, and Dr. Anna Bader from radiology. Does anybody have any questions before we start? Go for it.
Hi, good evening. Do you agree with age being 50 as a starting point for screening?
You stole my first question, so this is perfect. I planted that question.
This is the starting point. It was actually 55 in 2015, and this was updated in 2021 because we've been giving, the lung cancer community really has been giving USPSTF a lot of feedback about it's too rigid. But, you know, the no screening is without potential downsides. And what really we're aiming at, and I think we will get there in the not too distant future, is screening based on risk, because this takes into account really only smoking and age. And it's sort of patterned really after the other cancer screening programs, which are really based on age only. But we know that there are other risks for lung cancer besides that. So we don't want to screen people who are at such low risk that the scan is not worth doing. It's a tiny bit of radiation, but it is still a tiny bit of radiation. And a CT scan is really a look at every organ in your chest. And so we also don't want to find red herrings that are going to make us do other evaluation that's not necessary. So this is not the end. This has kind of been the beginning. And at some point, we will be using the kind of risk calculator I just showed and other methods of determining risk to decide really who should be screened.
So Dr. Tanoue, to that point, I guess, as a follow-up, this is a technology that's been around for decades. We've looked at CT scans for a long time. What do you see on the horizon as the next step for lung cancer screening, given that imaging has some inherent limitations and not all patients are eligible?
So I planted this question. Okay, so I'm going to take 1 minute and talk about this iceberg, which is actually addresses your question as well. So if you look at this iceberg, the top, and we call this, you know, the population that might get lung cancer. The top of the iceberg is a piece we can see. We know those people who are 50 to 80 and with that smoking history are at high risk because we can measure it. And so we're screening them. We want to screen them. We're only screening 5% of them. Please get the message out there that we should be screening. But what about everybody else who doesn't fit in those criteria? And some of them are non-smokers, right? Some non-smokers get lung cancer. The incidence is much lower than if you smoke, but still, there will always be people who don't smoke who get lung cancer, even though they're a minority. And we should be able, you know, with all the science that we have now, all the discovery, to identify those people based on blood tests or breath tests or tests that haven't been invented yet. And I think that, again, is around the corner. It's not like 50 years from now, it's like within the next 10 years. I think we will be using different tests to identify who in that iceberg that we cannot see because they don't meet those criteria should be screened. Yeah.
Great. A question for Polly, actually, as we were sort of going through this and talking about government websites to go to, how do patients in this room for family or friends actually contact us specifically to get more information about lung cancer screening and to find out if they're eligible?
You mean to contact us here at Yale?
Correct.
So we have phone numbers that you can call. Your primary care providers can put in a referral. We're happy to talk to you. It's pretty accessible. It's not the problem we're having with lung cancer screening are not the people that want to be screened getting in. It's the other people that either don't know about it, they need some education, or there's stigma attached and they don't want to come in for fear of the test, fear of the results. So that's more of the challenge.
Sounds great. Dr. Bader. So to that point, patients can access their CT scan reads by MyChart. And most patients, when they come into clinic, they have already read through and have earmarked each of the abnormalities that are there. Small nodules, a lot of anxiety over small nodules. So how do you consider these small nodules and offer guidance to patients who may have anxiety about what they represent in light of what we're hearing about tonight?
Thank you so much for organizing this and for inviting me to be part of this panel. It's such a special opportunity to meet our patients and work with our providers and to be in the same room with all of you. As my colleague from pathology mentioned earlier, as a radiologist, you probably will never meet me and will never see me except for the last line of the report in MyChart. So lung nodules are, as Dr. Tanoue mentioned, there's a CT scan is a look at a CT scan of the chest is a look at all of the organs in the chest. So there's lots of different things that we might find that may or may not be significant and may not be important. Lung nodules is obviously the primary focus of the lung cancer screening CT. And there's lots of ways in which lots of characteristics that we think about when we look at nodules and try to decide how concerning they are. So there's obviously the size of the nodule is very important, but also the location of the nodule, the shape of the nodule, how many nodules there are there clusters? Are these nodules the same as they were maybe, from the lung cancer screening CT a year ago or another CT scan that you may have had 10 years ago? So there's lots of different features of the nodules that we think about when assessing risk. And we try to guide follow-up based on that. And sometimes no follow-up is necessary. Obviously in lung cancer screening in the program, we do annual follow-ups, and sometimes another CT scan sooner than a year from now might be necessary, and sometimes more testing is necessary.
Great. And just to keep us on track as far as time, I had one more question for Polly for the audience. Patients don't always fit into the box that Dr. Tanoue has sort of outlined for us by age or smoking history. Patients get very anxious about family history. They get anxious about environmental and occupational exposure. They get anxious about friends who have cancer who had similar exposures to them, but not smoking. What do you see on the horizon as being opportunities for expanded screening, specifically, some of these key points that where we're seeing a lot more lung cancer, especially in never smokers?
So there is a lot of research about how to screen the most optimal population. One of the things is screening's been proven to help mortality if you continue to screen. It's not a one and done. So one of the things that really makes me pause is when someone screened 5 years ago and hasn't come back, and then 5 years later now has a lung cancer because they weren't getting their annual screening. So Krista, the nurse from the screening program, and I spend a lot of time navigating and calling patients and getting them back. But there's also a lot of research about people that were missing. Like the American Cancer Society right now is lobbying to get rid of the quit date. So if you're 50 and over and have a 20-pack-year smoking history, and doesn't matter when you stop smoking, should we be including those folks? We also know that with our screening guidelines now, probably 40% of women of color would not meet that criteria. So there's a lot of research going into that, and also family history. There's a great study now at Dana-Farber called the Inherit Study that's looking at people that have family history of lung cancer. So there's a lot of research that's going on that we hope will inform our eligibility criteria moving forward. But I think the first thing that's going to change is to get rid of the quit date.
Great. And our last question for Dr. Bader, and it was asked before, but we'll ask again. How has artificial intelligence, a buzzword that we use for everything now, made its way into the practice of radiology, and how is that being used as an opportunity to improve lung cancer screening?
Thank you so much. So AI is definitely a buzzword in all facets of our lives now. And hopefully, before we're all replaced by robots, the robots will help us do our jobs better and faster and more accurately. In terms of actual lung nodule detection and assessment, we're really in the exploratory phase of using it in clinical practice at our institution at Yale. We actually have multiple products that we're using, evaluating, and reevaluating within the radiology department of helping us assess nodules and be better at detecting them and tracking them. However, there's lots of different areas in the whole process where AI can help. So starting from a more efficient appointments, decreasing the radiation dose on CTs, for example, using deep learning methods, tracking patients and helping ensure that patients come back for their screens, making reports, so making it easier to report out the findings and compare reports and compare CTs over time. So there's so many different challenges and problems that AI could potentially help us solve, and we're very excited about the development of these tools.
Sounds great. Any other questions? We are moving into our last section, the home stretch, and probably the most exciting in terms of innovation, research and technology. And we'll bring up Dr. Goldberg and her crew, including my boss, who's sitting right there. And we'll finish up.
Great, thank you to It's a fantastic panel. Thank you all so much. So as Dr. Blasberg just mentioned, we are into our last part of the evening. So this is a session that's focusing on research. So just getting rid of the iceberg. There is an iceberg in research too, but we're not going to talk about that. So let me first introduce our amazing panel. So I'm going to introduce you, but feel free to talk a little bit more when I ask you your first question about what you do. So first we have Dr. Ann Chiang. You already heard from Ann because she moderated the panel before, but Ann, I don't think you really introduced yourself. So Ann is a medical oncologist, thoracic oncologist who close colleague of mine, and she focuses on small cell lung cancer, but treats all types of lung cancer and also does really amazing research. Actually, everybody up here does a lot of amazing research and others in the audience too. But Ann does fantastic research, particularly on small cell lung cancer. Who do we have next? Dan? Dan Baffa is next. So Dr. Baffa is the chief of thoracic surgery, also does incredible research, which I'm going to ask him to tell you about. And then, oh, So-Yeon Kim, another one of our amazing medical oncologists. So Dr. Kim is part of our lung team. So she treats patients with lung cancer, but she also is a physician and a researcher in the phase 1 unit. So she has kind of a foot in both clinics, and I'm going to have her tell you all about that afterwards. And then we have Jen Pope, who has been amazing at helping to get the microphone out to all of you, but also what she does in the rest of her time is she's the clinical trials team manager for the lung cancer group. So she helps to make sure all of our trials run smoothly. We have a lot of clinical trials that are trying to find better treatments for our patients, and she kind of makes it all work and leads a whole group of people who put it all together and get the trials to patients and make it safe and functional. And then Katie, is that you at the end there? So Katie Politti, she is a physician. Oh, no, she is a scientist. She's a basic scientist, a cancer biologist. And you heard from her already talking a little bit about her research, and she's going to tell us some more. So Katie works so closely with the clinical team. That's why I just by accident called her a physician. And she just knows so much about lung cancer on the clinical side, about patients, but also, of course, in the lab, and really is able to bridge those two areas to figure out what is happening with lung cancer, why it happens in the first place, why it grows, how to best tackle it. So an amazing researcher. So this is a fantastic group, and I'm going to maybe open the floor for questions in case anybody has a burning question to start out with, but I have a whole bunch of things I want to ask everyone. So anything to start out? Okay, I'm going to start then, and then hopefully you could think of some ideas of questions you want to ask this group. So Katie, I'm going to start with you at the end there, because I think a lot of the research that makes it to patients that maybe some people in this room have even seen in terms of clinical trials, it all has to start somewhere, and it starts in the lab typically. So I just wanted to have you talk to the group about what you do and then how that becomes treatments. How do we start in the lab, in cells, in mice, or whatever research is working on, and then how does it get through to patients, and then how do you even think about what to look at, what to study, how to start, where to start?
Yes, thank you, Sarah. So some of the things that we're really interested in understanding in the lab are understanding how does a cancer even start? And what are the molecules and the pathways that are involved in that? And then once a cancer has started, what happens for it to grow and to change? And what happens for it to metastasize, for example? And so we really try to understand all of those different steps. And to understand those steps, one of the things that we do is we use models. So we develop models. We can have models that are cell line models, so we can grow cells from cancers, and so we can study all the different pathways and the molecules that are involved in the cells. We can also generate models that are mouse models, for example, and that gives us an opportunity to study the cancer in different tissues, for example, growing as if, so for a lung cancer, we can actually, some of the things that we can do is we can actually turn on specific genes that we know are altered in tumors in people, and we can turn them on in the lungs in a mouse, for example, and we can see the tumor develop and study what happens. So a really important part of the work that we do is having these models so that we can study different things, the protein, the DNA, the RNA, everything that's involved. Then one of the other things is once we have the models and we start to get some information on the pathways, then we can start to think about which are the pathways that that cancer really depends on to survive. And we can try to then interfere with those pathways. We can try with drugs, but we also have a lot of tools that we can use, like genetic tools. So you've heard of CRISPR, for example. So we can use this CRISPR tool to modify genes that we think might be important for the cancer. And so we can use that as a tool, because then maybe if we know that that gene is important, then maybe we can work and develop drugs. And so the other side of the work that we do is understanding these pathways, understanding the molecules. And there we work in a lot of people are working on understanding sort of the proteins that are involved in a cell and that give the wrong signals to those cells. And the proteins are the ones that then we can target with a lot of these agents. And so we really need the science that goes behind understanding how, for example, a mutation changes that protein. Because then if you know why that protein, how it is different, then you can develop a drug that is for that different, the protein that has that different, that is a little bit different than what that protein would normally be like. And so then you get sort of that therapeutic effect of the drug. And so you need a lot of studies of those. So those are some examples of some of the things.
Thank you. I know you could talk for hours on this subject. So Jen, I'm going to turn to you next. I think we talked about this before in a few of the other sessions about it. There's a lot of kind of false information out there or confusing information out there online or what gets discussed. I think there actually is a lot of misunderstanding about clinical trials and what they mean, what they are. I think I've heard a lot of people say, well, I wouldn't want a sugar pill. I want to get treatment. So can you tell us a little bit, just generally, what is a clinical trial? What are some of the types of trials we have? Do they always involve placebo or what people call sugar pills? Tell us about kind of what we have.
Sure. So a clinical trial is a test of trying to figure out if a new potential treatment is better than what we're already giving to patients. So usually we're asking the question, comparing either adding an additional drug or testing a new combination of drugs compared to what a standard therapy might be. So we do have some trials that have placebos, but we're never, giving a placebo in place of a drug that we know works. We're adding additional things or testing a drug where you might not have gotten a drug before in your treatment.
And we have all different phases of trials. Some of our early phase trials, like Dr. Kim runs, we might offer only in New Haven or North Haven, but we try to bring those trials out to all of our centers across the state. So we're hoping that we can bring trials to where patients are, so you don't have to travel all the way in to New Haven or North Haven to get your treatment, and those are really available across the network. So hopefully some of you have been working with my team already, or potentially will down the line.
Great, thanks. So Jan, maybe since Jen was just talking about phase 1 trials, do you want to tell us about what you do in the phase 1 clinic and why might someone think about a phase 1 trial? How does that work?
Sure. So hi, I'm Soya, and I'm one of the thoracic oncologists, and I also participate in the phase 1 trials. And I just wanted to see how many patients have been part of a trial by show of hands. And by show of hands, how many patients have been part of a phase 1 trial? Okay, I have to do better. So in a clinical trial, as Jen mentioned, so it is experimental, meaning that we are looking at drugs that have not been approved by the FDA. And there's different phases of trials. So it goes from phase 1, phase 2, phase 3, and phase 4. And the phase of the trials depends on the stage of the drug development, meaning that if a drug is successfully developed in the lab through either cell line models or animal models, then it gets evaluated in the clinic. And the first time that it gets evaluated in the clinic is when we develop phase 1 trials. And it sounds scary because these are we call it first in human trials. But I think we've done so much better where previously, maybe decades ago, the responses to drugs, meaning whether you'll have a tumor shrinkage or not, have been usually less than 10%. But now with more targeted therapies and sometimes with immunotherapies, we've seen responses better, 30%, 40%, sometimes more than 50%. Not all of these drugs will be successful, and being transparent, I also don't know which drugs are going to be successful. But phase 1 is when you first study it in patients, and really the goal of it is to understand how safe the drug is and also what the best dose is to move it to a phase 2 trial. And during phase 2 trial, we look at the drug in a bigger population of patients to better understand, what is the best dose also in phase 2, but also how effective is the drug. And once it passes through phase 2, then it goes to phase 3, where they look at it in even a larger population of patients. And typically in a phase 3, there is this, some patients say, well, I get a placebo pill, but this is when I think maybe a placebo might come in during a phase 3 trial, where you're looking at the new drug that we're developing and comparing it against, I wouldn't say sometimes it can be placebo, but we're just comparing against what we call standard of care, what's already approved by the FDA. And usually after phase 3, sometimes with phase 2, that's when their drug undergoes specific scrutiny. And then if the FDA feels that it's an effective drug and a safe drug, that's when the drug gets approved. And in phase 1, I think there's a common misconception that it's sort of, the last thing that we'll try before maybe hospice. But I think because drug development has advanced so much, and also there's a lot of specific guidelines, and also we will hold your hand as you go through these trials. The best time to look for a phase 1 trial is, I think, when you're first diagnosed with a cancer. Regardless of, usually I see patients with advanced cancers in phase 1 clinic, but anytime you have a new diagnosis, that's really the best time to look through trials. Just because you sign up for a trial doesn't mean you have to stay with it. You're the boss, and I'm really just there to guide you and to help you understand the process.
Awesome. Thank you. Dan, I'm skipping over you. We're going to come back to you because I wanted to ask Anne, because I know Anne does a lot of work on clinical trials for small cell lung cancer. We haven't talked too much about small cell today. So do you want to just give us a brief update on how clinical trials are going? And there's amazing things happening in that area. Maybe just some of the highlights of how we're doing with small cell lung cancer trials.
Yeah, I think small cell is the advancement in the field it mirrors what's happening in non-small cell. And just this year, we've had two major developments that are advancing a field that really hasn't had so many developments in the past several decades. So we're really excited about that. And it comes from exactly what Katie was talking about. It comes from understanding the biology of small cell and then how can we leverage what we know about the tumor to cause it to go awry and die. So I think that a new drug is called tarlatamab. We had that trial open here at Yale. And it is a bispecific antibody, which means that it's an antibody that one head recognizes the cancer cell, DLL3, a protein on the cancer cell, and the other head recognizes CD3, which is part of the immune system on the T cell. So it's called a BiTE or a bispecific T cell engager. And we know that small cell is a kind of a cold tumor. It doesn't really have as many T cells that are around in the tumor and the tumor microenvironment. And so in this way, this bispecific takes the immune system and brings it directly to the cancer, and that actually shows a really nice response rate of about 40%, where you're shrinking the tumor, and an additional 30% where you prevent the tumor from growing, and at about 6 months, 60% of the patients are still doing well on that, and we're still learning from that. So that went from a phase 1 trial, actually with dose expansion, and then directly, because of the effects and because that area is there's an unmet need there, it went directly to FDA approval, accelerated. And so that's when you can see in real time how this kind of cutting edge technology can not only can benefit you and your patients. So I always talk to my patients about participating in clinical trials when I meet them. Some of you know that. Because I think it's the best care. You often have a whole nother team of research nurses that are taking care of you along with our regular team. So you have more eyes to care about you and think about you. And what I often say is that, it's not for everybody. There's some on one end, some patients will say, I'm so glad that clinical trials are happening. I'm at Yale. I know it's something that you do, and I'm excited to benefit it, but I don't necessarily have to be the person going through that. And that's really understandable. And then other folks will say, I like that idea. I know there's no guarantee that I'm going to get the benefit, but if I can participate in something like this and help others by doing so and potentially help myself, then I'd love to do it. And so we're going to be your doctors either way. But when you can really see that benefit in real time and patients doing really well on that, it's really exciting.
Okay, thank you. All right, Dan, I saved you for last. I think the research that you do is so impactful, but very different than what we've talked about so far. So I'd love for you to just give a brief summary of what you do and kind of some of the differences that it's making. This will be the last question unless anyone has anything else in the audience, and then we'll wrap up. So Dan, go ahead, tell us about your work.
Well, first of all, thank you for letting me kick off the second half of tonight's event. Really appreciate that. The audience participation, how many have participated in trials? I'm going to ask the question, how many people in the audience have done something today to make cancer care and medical care better tomorrow? And you all can raise your hand. And the reason is the type of work that every time you go to your doctor, every time you have a test, that information is recorded and is available to help inform the personalization of care for tomorrow. And that's what I work on. So I work on using what we call real world data. So the clinical trials, those are generally healthy people. Those are generally people that have a certain amount of resources and have very specific cancer scenarios. But what about the rest of us? And who may not be able to make it to all these appointments or may not be able to do all of those things. So I study the big databases of data, and I'm using cryptography, much like is used in Bitcoin, to create a token so that we can put all the pieces back together for all the cancer patients in the United States. And so you may ask, well, why does that even matter? What does real world data tell you? So I'll give you an example. So when the screening guidelines for breast cancer were developed, they were largely done without considering a lot of important attributes like race. And so as a result, the breast cancer screening guidelines are perfect unless you're any other race than white, because every other race other than white women get breast cancer 10 years earlier. So we've set all of these guidelines based on information that was incompletely informed. And so I think it's critical that, for instance, there's a breast cancer medication that's very effective unless you happen to take a certain heartburn medication. So you have to be able to take all of this stuff into consideration. And we are these complex puzzles of a million pieces. And if you don't look at all these things, you're not going to come up with the right answer for me, because I don't care what works in general. I care what's going to work for me. And so that's the kind of research that I work on.
Fantastic. Thank you. So any last questions from the audience before we wrap up? Yes.
A lot of wonderful things about trials and treatments and drugs that are available and research teams put together. And I'm just wondering, is there any research being done on the effects of good nutrition and how it affects cancer patients? And are there going to be guidelines for cancer patients to keep them on a healthy track? Because we are what we eat, and nutrition and a healthy body is got to be the most important thing when you're fighting any disease.
It's a great question.
I'd love to hear more about, nutrition.
I would say of all questions that I get asked in the office, that's probably number one, right? I think that's so important. It's something we can also control, right? We can potentially change what we eat. So I will ask our panel, would anybody like to tackle that question? It's not an easy one.
I'll give you, I think the short answer is we don't know. Like, I don't think you can pinpoint that eating a balanced diet. I don't think there's enough evidence to say that a lot of common sense habits and routines and lifestyle choices impact your outcome during cancer treatment, other than you want to maintain a reasonably healthy diet. You have to maintain your nutritional status. But I agree with you. Of course, eating a healthy diet is going to make sense. But what I can tell you, what there is very strong evidence for is, in terms of lifestyle choices, is not smoking during your cancer treatment and after your cancer treatment. All of the, again, so common sense, probably, but there's just not the same, I was in mainstream media like crazy over the past 2 years for wildfire smoke exposure. There's so many different things in our world that we know are not healthy and probably contribute to cancer specific outcomes. And so I think there's a common sense piece that, we say you're never going to test the efficacy or the effectiveness of a parachute. There's never going to be a randomized trial. It's just kind of common sense. But in terms of, I think we are more frequently asked, I get asked about low sugar diet. I get asked about blueberries all the time in Connecticut. I don't know if the Blueberry Association is like funding some stuff, but stopping smoking. So we've talked about driver mutations, checkpoint therapies, immunotherapy. Quitting smoking will save more years of human life during your cancer treatment and after than all of those other interventions combined. So smoking cessation is incredibly powerful. And so that just goes along. I know that wasn't your exact question, but it's a lifestyle choice. And so we can change our lifestyles and make a huge difference. And I'll just make one other screening pitch. So Lynn showed this slide and 25% survival. I don't know if you guys caught that. I mean, who the hell wants to find something that's got a 25% survival rate? That's ridiculous. The cure rate of screen detected cancer is like in the 90s. So you have something that on average kills the vast majority of people. If you get it detected by your screening, you're almost certainly, not certainly, but you're extremely likely to be cured. And that's such a game changer for us. 30 to 50,000 people die each year in the United States that from preventable deaths because they didn't get scanned. They were eligible for scanning. If you scan 300 people, you know, every little kid wants to be a fireman when they grow up because they want to save people. You get 300 people scanned, you will save a life. That's like dragging a human being out of a burning building. Just 300 people. So it's a huge intervention.
Okay, we are over time. Anne has a very important comment she wants to make, and then we're going to close. Anne.
Well, I encouraged you to ask the question, so I feel like I have to answer it or at least speak to it. I think that's an area we need more research on, and we've talked about that. I think that, you know, metabolomics, how we deal with sugar in our body, processed foods, our microbiome and how what we eat affects what bacteria are in our gut. Those are all super important questions. Madelyn talked about our integrative medicine department, and I do think we have folks who speak to that, but areas of research, I think this is one that has a lot of opportunity, and we hope to, you know, continue that vein.
Yep.
Thanks for the question.
Great comments. All right. Well, thank you so much to our panelists. Amazing comments, and thank you for all of the research and work that you do. And thank you all again for coming, staying so late. Really, really appreciate you being here and wanting to learn more. So hope to see you next year.